Subhash Mukherjee Oration, and I would request again Ganapati sir to actually introduce the oration, and then maybe Dr. Murthy can introduce the speaker.
Yeah.
Can we have
Thank you.
the projection, please?
For those who don't know who is Professor Subhash Mukherjee, he was an Indian scientist, physician from Hazaribagh, Bihar, and Orissa province, British India, now in Jharkhand, India, who created the world's second and India's first child using in vitro fertilization. He did his MBBS in 1955 from the Calcutta National Medical College, PhD in 1958 from Raja Bazar Science College campus of University of Calcutta in reproductive physiology. He is the second PhD from the University of Edinburgh in 1967 in reproductive endocrinology.
Thank you, sir. And if you could project the slide of Professor Anirban Majumdar, please, the orator. Yes, sir.
It is indeed a proud pleasure to introduce Dr. Anirban Majumdar, Professor KPC Medical College and Hospital, Calcutta, Conjoint Professor, School of Medicine, Public Health, the University of Newcastle, Australia, Fellow of the American Association of Clinical Endocrinologists, Regional Faculty for Certificate in Evidence-Based Diabetes Management of Public Health Foundation of India, New Delhi, Publications National and International, Journal 66, Principal Investigator of Phase 3 Clinical Research 6. Welcome, Dr. Anirban Majumdar, and it's indeed a pleasure to invite you to deliver the Professor Subhash Mukherjee Oration 2021.
At the outset, I'd like to convey my sincere thanks to the organizer for this invitation, and I convey my deep regards to this noble man, Dr. Subhash Mukherjee, who was the pioneer of the in vitro fertilization in our country. So my today's talk is Gender Incongruence, Approach and the Endocrine Management. And I'll go through this introduction, how I make the diagnosis, the management, and the challenges I actually encountered during my clinical practice, and I will wrap up with the take-home messages. So first question is, how many types of gender we have? Now we all know that we have the male, we have the female, however, we also have a third gender, or the kinnaras. The concept of this kinnaras was there since the ancient time in our country, and it was reflected in our literature, in our mythology, in our paintings, in our scriptures, and also in our culture. So a huge number of people actually under this condition, or they belongs to this group or the third gender. However, we did not have any idea about the prevalence of these people in our country. In 2011, in the last census, the government of India has tried to make an understanding about how many third gender people or the transgender people present in our country. And it was estimated to be roughly around 5 lakh transgender in our country. Because of the pandemic, we did not have the census in 2021, so we don't know the exact number at present time. However, this 5 lakh population is quite an underestimated figure because majority of the transgender society, they believe that this is much less than the actual number we have in our country. Now, if we look into the prevalence of the transgender or the third gender community in the other part of this world, where the prevalence study has been done, it was roughly around 0.3 to 0.6%. And if we take this 0.3 or 0.6 in between as a prevalence in our country, the number may be at least 10 times than what is estimated by the last census in 2011. Now, coming to the risk. Now, why we are talking about what is the problem, why we should think about them, because the fact they have a high prevalence of suicide. We do not have much data about the suicide among the transgender population in our country. This is the only data which was published in 2016, and the suicidal attempt rate among the transgender person is 31%. Now, we have looked into our data which we have published very recently in 2021, and we have found roughly around 25% of our patients or transgender subjects who attended our clinic actually had suicidal thoughts and attempts in their life. So let me remind you that these are the people who have survived the suicidal attempts and then attended our clinic. And we don't know how many transgender subjects actually commit suicide every day in our country or every year in our country. Now, coming to the issue of the third gender or kinders, which is my topic today, and hijras are considered as the officially recognized third gender in our country. Now, if we consider the third gender, then possibly any people who is not heterosexual or cisgender should be considered under this heading. It is called as genderqueer. Some people say that they're the rainbow community. And the largest group among this third gender is basically the LGBT community. I think all of us are actually aware about this group, lesbian, gay, bisexual, and transgender. But some of the subjects we find that they actually are confused about their gender identity, and therefore we keep them under the heading of questioning. So the whole group extends to LGBTQ. Now, apart from this, there are some people who actually believe that both male and female sex present in them, and they are considered under the heading of two-spirited. So the group extends LGBTQ too, and apart from that, if you consider the intersex disorder and the asexual, those who believe that they are neither male nor female, and also the allies, actually those who support this group of people, if we consider that the whole group extends LGBTQIA, it is a quite big group. And then we have also the bigender, who actually moves between feminine to masculine gender identities and behavior depending on the context. And also we have the transvestite, the person who wears the clothes designed for the opposite sex. So the group is big, but my topic is actually the transgender. It is only those people, though, who belongs to this transgender community who actually get benefit from the hormone therapy. So therefore, I will concentrate on the transgender or the gender incongruence. Now, gender incongruence, they are either they are male, but they have a different gender identity. They take up the female gender role, or they are female and they take up the male gender role. So we call them as transgender women or transgender men, depending on their natal sex and depending on their preferred sex or the expressed gender. So previously the terminology was different. It was called a gender identity disorder as far as DSM-4 criteria. In DSM-4, they actually given this definition that when there is a strong and persistent cross-gender identification is present, along with persistent discomfort with one's sex or sense of inappropriateness in the gender role of that sex, then it signifies a significant distress, and that is the diagnosis of gender identity disorder. However, people thought that the disorder is not a very good terminology to call them, so they have given a different terminology. It is gender dysphoria. This came with DSM-5, and very recently in 2018, WHO said it should be considered as gender incongruence. It is not a psychiatric disorder. It is a way of life, so we should not call it as disorder or dysphoria. It should be considered under the heading of gender incongruence. However, many people who have gender incongruence can have distress and can have gender dysphoria, and therefore this dysphoria needs to be addressed. Coming to the diagnosis. Now, what is gender incongruence? As I've told you, it is a term refers to a person whose sex assigned at birth does not match with their gender identity. Some of them experience gender dysphoria, and it should be done with the help of at least one psychiatrist or the psychotherapist. So I heavily depend on my psychiatric clinic to get the diagnosis done, not only because of the diagnosis, but also to get an understanding that whether they are suffering from any psychiatric comorbidities or not. So recently we have published this consensus statement, and in the consensus statement we have highlighted this issue that we need to send the patient to the psychiatrist to get the diagnosis and also to get an idea about the psychiatric comorbidities. So this is the DSM-5 diagnostic criteria for gender dysphoria, where, as I told you, the person should have a strong desire for the primary and secondary sex characteristics of the other gender. So when you have the diagnosis, if you look into our experience, which we have published around 5 years back, then their mean age of presentation was 25. However, if we look into the Western data, the mean age of presentation of this group of people was quite younger. Sometimes they present in the pre-pubertal stage or during the puberty. And in our cases, their presentation is quite late. Possibly the social circumstances are such that they present at a late age. Sometimes even they present above the age of 40 as well. Coming to the management issues, the management should follow a very, very basic protocol-wise formula, or as laid down by WPATH guideline, that is World Professional Association for Transgender Health. And these guidelines suggest that we should go for a stepwise approach. First, we should go for the psychotherapy, and the psychiatrist will try their level best to address the negative impact of the gender dysphoria. Second, we have to counsel the patient to go for the real life experience, that is to live part-time or full-time with another gender role. In other words, cross-dressing. So the patient should do the cross-dressing either part-time or full-time, and should get an idea that how he feels about it and whether they are comfortable with this cross-dressing or not, or either in a different gender identity they are quite comfortable with that or not. And then we'll start the hormone therapy, or in other words, the cross-sex hormone therapy. Then they should be subjected for the surgery to change the primary and or secondary sex characteristic. And lastly, some ancillary measures can be taken, like voice therapy, hearing loss, so on and so forth. So classically, it should go within these 5 stages one by one, and sometimes we have found that the people actually skip the stages, and that sometimes be very devastating. So we need to aware the people that all the people who suffer from gender incongruence or gender identity disorder should go through this stepwise approach, so that the treatment is quite effective, and there should not be any regret after the treatment is completed. Now, coming to the endocrine part, what is the endocrine management as far as the gender incongruence is concerned? We try to develop the physical characteristics of the affirmed gender, and we have to give the hormone in a safe and effective way. We actually try to suppress the endogenous sex hormone secretion, and we try to maintain the sex hormone level within the normal range of the person's affirmed gender. And this cross-sex hormone therapy is not recommended for prepubertal gender dysphoric or gender incongruent person. Their treatment regime is slightly different. I usually don't treat the prepubertal or pubertal boys and girls. I usually concentrate the treatment only for the adults. Now the treatment should be based on the guideline. There are a lot of guidelines available to us. This Endocrine Society guideline came in 2009, and then a repeat version we have. The WPATH guideline was, we are using the 7th version at present. 2011 it was published, and we are going to have the 8th version in next year. And very recently, in last year, we have actually published the Indian Standard of Care, or the Indian Specific Guideline in 2020. And before we start the hormone therapy, we have to see the readiness or eligibility criteria for the cross-sex hormone therapy. The person concerned should take the hormone in a responsible manner, should have some knowledge and understanding about the expected outcome. They should not have any unrealistic goal or unrealistic expectation from the hormone therapy, which is often there among the transgender people, that after giving hormone they can transform their sex over a period, with a short period of time, say 1 month or so. And they must have at least a documented real-life experience for at least 3 months duration, preferably of 6-month duration. So once these criteria are fulfilled, and if the subject is mentally stable, then actually we feel that they are quite suitable for the cross-sex hormone therapy. So this is, we have published very recently that how we should go about it as far as the evaluation and the counseling before the hormone therapy. First, we take the consent of the patient. We do the physical examination. We evaluate the patient in the lab, especially the hepatitis B antigen, because many of them suffers from this hepatitis B, and very, very importantly is the AIDS or the HIV. So that infection is also quite common among the transgender population. We have to counsel them about the risk and benefit of the long-term hormone therapy, and we have to counsel them about the good lifestyle, especially the substance abuse, and very, very importantly is the gamete preservation. Once you start the hormone therapy, and especially once the patient have actually gone the surgery, then quite naturally patient will not have his or her own baby. So if somebody is interested to have his or her baby, it should be discussed before we start the hormone therapy, and we should discuss about the idea of the gamete preservation if they so desires, and that gamete should be preserved for the future use if they want to have their own baby. Many transgender persons are very, very interested to have their own baby. Coming to the endocrine management of male to female, it is little bit complicated. We start with the feminizing hormone therapy, and we have lot of options, lot of estrogen preparations are available to us. Which preparation we should use, it depends on the treating physician. There is no head-to-head study between different estrogen preparations as far as their benefit and side effects among the transgender population. Usually we have to give supraphysiological dose. Usually this dose we don't use normally among our female patients. For the transgender, the dose is quite high because we have to give supraphysiological dose to reach an adequate hormone level. The choice of agent depends on the availability, the side effects, as well as your cost of the therapy. Transdermal estradiol is basically quite safe. It have much less side effects, but it is not easily available in our country. Now, as I told you, the hormone therapy is associated with lot of risk. So on every visit, when the patient comes for the follow-up, we have to look into whether the patient is developing any complications or not. Thromboembolic disease is basically well discussed almost in all literature and all the guidelines. However, our experience says that the thromboembolic disease is not common. At least for the last 15 years, we have treated so many transgender subjects, maybe more than 200, but I have not seen a single case of thromboembolic disease. The data of the thromboembolic disease with estrogen therapy was basically derived from postmenopausal women and their data. So it is a derived data. For the trans women, I don't think it is a major issue. Last time I have seen one study published, observation study published from USA, they say that the thromboembolic disease is about 0.1%. This is quite low as far as the side effect with the estrogen therapy in trans women is concerned. Now, the expected benefit of the estrogen therapy will take some time, say a few months, 3 to 6 month period of time, and we can expect the maximum benefit to come after 2 to 3 years period of time. So we have to counsel the patient that you should keep on continuing the drug for a long period of time to get the maximum benefit. They are always in a hurry. They want to get the things done or get the things happen overnight or within a month or so, but the estrogen therapy takes long time to give its benefit, and usually people are very, very concerned about the breast growth, and if we expect a good breast growth, then we should wait for about 2 years period of time to have an adequate breast growth. And if the patient is receiving estrogen for adequate period of time and with adequate dose, many of them actually will not require the breast augmentation surgery. Another important aspects of the trans women therapy is to give some drug to prevent the androgenic effect, and we have 3 choices in front of us, either GnRH agonist or spironolactone or 5-alpha reductase inhibitor, either in combination or alone. GnRH agonist is the most effective one, no doubt about it, but the issue is GnRH agonist comes with very, very high price. So because of the fact that it is very costly, so many of our transgender subjects cannot afford the GnRH agonist therapy, and it should be continued till the orchiectomy is done. So therefore we have to give it for a quite long period of time. And if the GnRH agonist patient cannot afford, then we have to give the spironolactone and 5-alpha reductase inhibitors. The giving progestin is little bit controversial. Some of the guidelines suggest that progestin therapy has got no benefit. However, as we have very recently published this idea consensus group consensus statement in 2020, all the panelists actually of opinion that progestin therapy will be very helpful. They help in feminization process, they help in optimization of breast maturation, increase the bone formation, and possibly it will have some cardiovascular benefit also. We conventionally use either drospirenone or micronized progesterone because they are safer agent compared to the traditional agent medroxyprogesterone. But if you look into the data available to us, there are very few studies that have been published very recently from JCM in favor of the progestin therapy among the trans women. So therefore, we always give progestin therapy to our trans women. So this is the target of the hormone therapy, that we have to reduce the testosterone level to less than 55 nanogram, and we try to achieve estradiol level between 100 to 200 picogram per ml. That is our target. Now this is a young boy who came to us in 2001 at the age of 15 and with puberty gynecomastia. And his parents were quite apprehensive about his breast development, but he was not. Now after one visit, he was lost in follow-up, and he came back to me in 2010, again with gynecomastia, without any treatment he received. But this time I found that he was quite depressed, he had suicidal thoughts, and he was quite confused about his gender and his identity. So after discussing, I found that he is possibly suffering from gender identity disorder. That was the terminology at that point of time. So I sent the patient to the psychiatrist to get a thorough evaluation and get to understand about the diagnosis. And the psychiatrist diagnosed him as a gender identity disorder at that point of time. So we have started the hormone therapy in this boy, and then he underwent the sex change operation. And 2013, actually, he was sitting in the couch as when he came for a follow-up visit. Now, if we look into our data, we have published long back 2017, outcome of the 55 transgender subject, and there were a lot of lost in follow-up, 25% actually lost in follow-up. The rest of them all actually passed through the real-life experience, received the cross-sex hormone therapy. Some of them undergone the breast surgery and orchiectomy operation. But very, very important is 25% of them actually lost in follow-up. Coming to the endocrine management of the female to male, which is quite easy because the testosterone therapy is very, very effective, and you can expect the benefit within a shorter period of time. We give either parenteral testosterone, or we have also the transdermal testosterone, but it is very difficult to get transdermal testosterone in our country. We conventionally treat the patient with parenteral testosterone, either enanthet or cyponate. And nowadays we have this testosterone undecanoate available, which can be given 1000 milligram every 12 weeks. It is quite comfortable for the patient because you have to give the injection in every 3 months. But however, the undecanoate has got its own limitations. Now, the target of the hormone is the testosterone to be maintained between 400 to 700 nanogram. And when we should measure, there is a lot of controversy regarding when to measure, but the Endocrine Society said that if you're using testosterone and enanthet or cyponate, you should measure in between the two injections. If you're using testosterone undecanoate, then you have to measure just before the next injection. And if you're using the transdermal testosterone, then you have to measure after 7 weeks of continuous application. And you have to see that whether you have achieved the serum testosterone level between 400 to 700 nanogram or not, and then adjust the dose of the testosterone. Now, some additional therapy may be necessary to stop the uterine bleeding. In majority of the situation, just testosterone therapy is sufficient and can stop the uterine bleeding. However, some of the patients may need an additional therapy to stop the uterine bleeding. So we give progestational agent, either oral progesterone or the dipomethylhydroxyprogesterone, or you can give generic analog also, but generic analog again will be a costly affair. Endometrial ablation is the last option in front of us. Most of the patient I treated with dipomethylhydroxyprogesterone, easy because you can give it every 3 months, so the patient don't have to take the tablet every day, and that is very, very effective drug. Now, looking into the expected benefit from the masculinizing hormone therapy will come after a few months of the continuous treatment, and we can get the maximum benefit after a period of 1 to 2 years. And as I've told you, this therapy, the testosterone therapy, is very, very effective as far as transforming the women to men. There are some risks associated with the sex hormone therapy, and on every visit we have to evaluate whether the patient is developing any kind of side effects with the testosterone therapy or not, and we have to adjust the dose. Now, this is the outcome of the 18 female to male transgender subject in our follow-up, and all of them actually gone through the real-life experience, cross-sex hormone therapy. Some of them actually went through the mastectomy, hysterectomy, and there was only one was actually lost in follow-up. These data was quite long back, published in 2016. Now, this is one of my trans men who was started with the sex hormone therapy in 2011 at the age of 20. He underwent mastectomy in 2012, and in 2013 he came for a follow-up with his girlfriend. So that is the success of the therapy, or the cross-sex hormone therapy. Coming to the challenges I faced, how I call them. So this is the guideline that for the trans male we should call as he or him. In trans female, that is from male to female, we should call she or her. And those who are gender neutral, we should call them as zine or z. Second important challenge is the diagnosis, because it is a rainbow community, as I've already discussed. So there are a lot of people inside this group. And as I've told you, that only the transgender will get the maximum benefit as far as the hormone therapy is concerned. And our hormone therapy is designed to give only those who have the gender dysphoria and those who have a diagnosis of gender incongruence. So we have to identify the transgender among them. Sometimes the transvestite do come in our clinic, but actually we have to look into whether they are transvestite or transgenders. Third important issue is the inappropriate surgeries, because some of the patients come after the breast augmentation surgery, after orchiectomy, without going through this protocol-wise management. It is done by, most of the time it is done by the quacks or semi-skilled professional, but let me tell you that sometimes it is done by quite qualified medically qualified surgeons. So we need to increase the awareness among the physician, our colleagues, our surgeons, that these group of people needs treatment, these group of people may need the surgery. However, they should go through the protocol-wise approach, they should go through the step-by-step approach so that the surgery become beneficial to them, and there should not be any regret, because we have seen some of the patients actually have regret after the surgery has been done. We have very recently published these 3 cases of castration in the Hijra community. We have seen a lot, but published only these 3. But anybody who is working in the field of this transgender medicine must have encountered this kind of castration, which is done in the Hijra community by the quacks, and actually it is a very, very devastating surgery, and it is very, very difficult to get a resurgery done to do some cosmetic improvement in the appearance. Sometimes the mastectomy was done very poorly, and therefore it again not a problem on part of the endocrinologist, but it is a big issue in front of the surgeon to get a redo surgery in the same place. There are some limitation of the estrogen benefit as well. As you can see that this patient has actually developed the breast after an adequate dose of estrogen therapy for 2 years. It may not happen always in all cases, or another patient who received the adequate dose of estrogen for 2 years have not developed much breast. This is well known. And you can see that this actually evaluated in, or actually shown in many other studies, that even after long-term hormone therapy, many trans women still have challenges in the size and shape of their breast. Therefore, every patient will not respond in the same fashion, and that should be in our mind, and we should discuss this thing beforehand with our patients, that you should not have any unrealistic expectation. However, as I've told you, many trans women who receives the estrogen therapy for a long period of time may not require surgical intervention. Now, another challenge is in the follow-up. As I've told you, that many of our patients actually are lost in follow-up, 25%, and I have not very recently looked into my data, but it will be close to 25% again if I look into my data at present. So lost in follow-up is an important issue, and at the same time we don't know how many of them actually had committed suicide in between. Another important issue is the quality of life. You can see this is the data from the Western countries, and they have repeatedly raised this issue that the quality of life among the transgender people in their country is quite poor. However, we have very recently published 2 quality of life or the socioeconomic status of transgender community in India. In the first study, we have looked into quality of life of the Hijra community, and we have compared them with the control, and the quality of life was not inferior to the Hijra group of people compared to the control. We have taken hospital employee as the control group, and there was no difference between the 2 groups. And looking into the socioeconomic status of the transgender community of India among our 120 gender incongruent subjects, we have found that the history of addiction is not much. Your 50% may look very odd to you, but if you compare with the Western data, they have 80 or 90% possibility of addiction, and that many of them are actually addicted to marijuana. But we have not found a single case of marijuana addiction in our cohort, and they receive good support from their family and friends. Their mental health problem is quite low. 3% is not a very big figure. So as far as the quality of life and socioeconomic status is concerned, at least those transgender who come for the gender affirmative care in our center actually have good quality of life and good socioeconomic status. So I will conclude my talk with some take-home message. Number 1, the gender incongruent identities should be recognized. Number 1. The lack of information and awareness among many health personnel often leads to risky procedures and inappropriate handling of the people seeking transition. We need to increase the awareness among our physician colleagues and also among our surgeon colleagues. Treatment is available to assist people with gender dysphoria to find a gender role that is comfortable for them. And hormone therapy must be individualized based on a patient's goal, the risk of medication, and the presence of other medical conditions. And very, very importantly, we should create a welcoming clinical environment for the non-binary gender-queer people. I convey my sincere regards and acknowledgement to my co-workers, Professor Shridip Chatterjee, Professor Debmalo Sannal, who is there, Dr. Soumyabrata Rajaguri, and Ms. Suma Chakraborty. And thank you very much for your patient listening.
Thank you very much, Dr. Anirban Majumdar, for that elegant oration.